Hello, everyone. My name is Dr. Richard Horowitz, and I am co-host of this great online summit called Healing from Lyme Disease, which is being sponsored by Doctors Talks. And it is my great pleasure to introduce to you today a very good friend and long-term colleague, Dr. Robert Bransfield. Dr. Bransfield is Clinical Associate Professor of Psychiatry at Rutgers Medical School. And I would say that Bob is regarded in the Lyme community as really being at the forefront of treating patients with neuropsychiatric symptoms. He's talked extensively about the role of microbes in mental illness. And Bob, why don't you tell the audience a little bit about yourself, how you got into Lyme disease? And today's talk is going to be about sleep disturbances and Lyme disease. So it's a great topic, and I learned a lot about this years ago from you.
All right. Thank you, Dr. Horowitz. We've been doing this a long time. Now, my original training 50 years ago was as a psychoanalyst, but that's how psychiatrists were trained then. And at that time, the thought that someday I'd be looking at psychiatric illness as being caused by tick bites was incomprehensible. But that's where the evidence has gone. And I've developed a specialty in working with treatment-resistant patients. And in working with these people, a lot of them ended up having infections that were driving their mental illness. And it just kept coming up again and again. And no matter how even if I try to escape it, and I'll say, can I see someone who isn't a Lyme patient? And I'll see a new patient who isn't a Lyme patient. And then I take a history and I think, my gosh, this is another Lyme patient. And it was missed. So the old belief, in fact, I was taught schizophrenia was caused by the schizophrenic mother. And what a horrible guilt trip. But that was the thinking at the time. And there were all these psychodynamic theories. And so when you look at it in a more comprehensive way, infection and immune reaction to infection plays a very big role in mental illness. And I just had a journal article that came out with on microbes and mental illness, past, present, and future. And it looked at that in a comprehensive way. And it really took almost 2 years to develop, and with my co-authors. And it really was a lot of work, but I think it's a major achievement. And that is on PubMed, and anybody can see it.
Right. So, Bob, just tell them this is in the journal Healthcare, right?
Yes, in healthcare. Yes.
Right.
And it's so it's online. Anybody can find it now.
Great. So question, we're mainly going to focus today, and we're going to go through a whole bunch of things on immune dysfunction and inflammation, because, again, we know that that's driving a lot of this. Tell me a little bit about sleep disturbances in these Lyme patients, and what forms do they take? Like, what kind of sleep disorders are you seeing in these type of patients?
Well, I basically see the whole gamut. And when I think of trying to get a disease model, I think it's like 3 interlocking circles. And 1 is infection and other disease contributors, 2 is the immune system, and 3 are symptoms. So if we look at symptoms, and those 3 things interact with each other, causing disease progression and disease perpetuation. And when I would do these assessments, and I've done thousands of assessments, and I'd go and ask 270 different symptoms associated with Lyme. And then at the end, I'd say, well, what's the worst symptom? If I could only, how do they all fit together in like a tangled ball of string? And if I could only treat 1 symptom, what would you want first, second, and third? And after doing this for thousands of times, usually the number 1 symptom to treat is sleep disorders, because non-restorative sleep is catastrophic with chronic illness. Now, if you look at the type of sleep disorders that patients have with Lyme and tick-borne disease, it goes the gamut of everything. So you see, but the big thing is the failure of the delta sleep, the deep sleep, because that has a lot to do with healthy immune functioning. But you can see sleep apnea, you can see obstructive as well as neurologically based sleep apnea. You can see restless leg, you see nightmares, and nightmares comes up a lot because a lot of patients with Lyme disease have these intrusive symptoms, and that can interfere with their ability to fall asleep, but it also causes nightmares and REM sleep later in the night. And then pain can interfere with sleep. So you break it down, sleep you break down into 4 phases. onset, and then also middle of the night, and then early morning, and then quality of sleep. And that's the way when you think, well, what is it? And if I ask someone, why aren't you sleeping? Say, well, I just can't sleep. You never leave it at that. You have to dig further. So if I say, well, in order to sleep, you have to be able to turn off your head, calm your emotions, and relax your body. What do you have the most trouble doing? And they really have to think about that. And often it's turning off your head. But if it's turning off your head, then you look at what's the thought content. Is it intrusive thoughts, racing thoughts, obsessive thoughts, worrisome thoughts? Is it calming emotion? Is it hyperarousal, emotional arousal, where they can't downset their arousal? Or is it something physical? Is it reflux? Is it palpitations? Is it vertigo? Is it some shooting pain or neuropathy? Is there something physical? And it may be more than one thing. And then you methodically look at what causes that, and then you treat it, and then you work your way down the list. And middle of the night is more commonly physical. Early morning can be depression. Poor quality sleep is lack of delta sleep.
So, Bob, you brought up something really, really important, which I think I need to highlight for the audience who's listening, which is you're talking about a differential diagnosis of sleep disorders, that you don't just say, oh, you can't sleep. Here's an Ambien. Here's a Lunesta. Here's a Sonata, right? You actually have to go through and say, listen, Lyme causes delayed sleep phase syndrome. It's a circadian rhythm disorder, but you can have obstructive sleep apnea. Even in a young, thin woman, right? You could get obstructive apnea or restless legs. So it's very important. Men with benign postherpetic hypertrophy, right? They're getting up to P or menopause,
Yes.
hyperthyroid. So the differential is really important. Now, normally, I don't think psychiatrists usually do this, but are you sending people for sleep studies to make this diagnosis? How are you figuring out the differential?
I do, although sometimes you can tell a lot just by a fairly quick assessment. One thing is just have the patient open their mouth and look in their throat. Now, some of sleep apnea, which is probably what we think of most commonly, is having a fat neck. So when you gain weight, that causes obstruction. But that isn't always the case. You can have someone who's underweight with sleep apnea, and when you just simply open the mouth, look in the throat, and is there a high tongue, low palate? And there are some people that have that, and they have internal airway obstruction just by their internal anatomy, and it has nothing to do with weight gain. And I'll do a simple thing. I'll say, put your chin down and breathe, and then put your neck up and breathe. Okay. And when you have your chin up, the airway is more open. A lot of people sleep like this with a pillow, and that's a mistake. They should prop their neck up so that they get better airway. So it's sometimes very expensive for these sleep studies. Now they're pushing people to do the at-home sleep studies first, and it can be about a $10,000 test. And so you need it, particularly if someone has narcolepsy and you're trying to prove narcolepsy and you're trying to give one of the narcolepsy drugs that are quite expensive. You have to go through that process. But also, if they have sleep apnea and need a CPAP machine, you have to do it. And there used to be very few sleep centers. Now there's tons of them everywhere, and they're competing.
Right.
But I do send a lot for sleep study, but you can do a lot yourself without going that far.
And I think it's a good point. I mean, I think the sleep studies are really essential, especially in the difficult one. But, have you ever used AccuSom or Novasom? This is an in-home sleep company that we have been actually recommending to patients, I think, for at least a decade. It's covered by the insurance most of the time. I don't know if you've had experience with them, but we actually have quite a bit of luck using them so people don't have to go into the hospitals to do the sleep studies.
Yeah, no, I'm not familiar with it. Although I think these CPAP machines aren't that expensive. And you can buy one, and sometimes the cost of trying to get it covered by insurance is greater than the cost of the machine if you just buy one.
Right.
So it's a lot of times people get stuck by insurance barriers, and when they go outside their insurance plan, a lot of times things are more cost effective, and you can't get paralyzed by the limitations of your plan.
Right.
And there are private things like that.
And you talk about that a lot with insurance companies about how to fight back, right? Like if you're not getting the treatment you need, what to do. But fortunately, I mean, sleep doctors now are out there. People have specialized in it. So if they can't get insurance coverage, do you sometimes refer to some of the sleep specialists apart from the in-home?
Yes, yes. And there's a number of them, and there's some that I know in any given area. And but and sometimes there's some dentists, because some dentists do some work with dental appliances, and these sleep studies can differentiate sometimes the categories. And the thing that people don't realize is the commonly prescribed sleep aids don't help quality of sleep. The only one like Xyrem, Xywav, but that's the for narcolepsy, and your average sleep aid really doesn't improve quality of sleep. It's drugs approved for other things that help the quality of sleep.
Right. And we're going to get into that in just a second because I've actually learned this from you a long time ago. There are many classes of drugs, right, which are stage 3, stage 4 REM sleep, right? They help to get them in it, but not ones that, in medical school we normally learn. In fact, maybe just mention them briefly. The types of general meds instead of just using the standards. What kinds of drugs do you actually like that you're prescribing to your patients that you find are useful?
Well, I think if you look at, let's say, statistics on what are the most commonly prescribed sleep aids, the number one sleep aid is trazodone. I think that has almost a 50% market share. Now, the irony is it was never approved for sleep. It was approved for depression, and it's not a very good antidepressant. But and the advantage to that is it doesn't cause addiction dependence like you have with what's called benzos or non-benzos, the commonly when we think of like Ambien, those kind of meds. And it doesn't cause weight gain, because a lot of your sleep aids like Benadryl and some of the antidepressants that are very sedating cause weight gain. This causes neither weight gain nor tolerance and dependence. Now, it has other side effects, and maybe not everybody tolerates it. And it promotes the delta sleep. So that's the most commonly prescribed sleep aid. And that's often where we start, and then we work our way down list if someone doesn't respond to that.
And
Try
the
other things.
dosage you're using of trazodone, Bob, you're starting at 50, you're going to 100. Where are you starting with it?
Right. No, normally I would say, okay, 50 milligrams, one increase to 3 if needed. Now, a lot of Lyme patients are very, very drug sensitive. So some people need a small fraction of a 50. And you usually know who those patients are. They're sensitive to many meds. And now what happens, and here's the thing, and I think it's true with many sleep aids. When you first started, when you're catching up on a sleep deficit, they may feel zonked for a couple of days, but you have to work that through, and they're catching up on a long-term sleep deficit. The other thing is if they get too much of a drug hangover in the morning. So let's say they're on 100 milligrams of trazodone and they get a 2-hour hangover in the morning. Then what you do is you give half the dose 2 hours before bedtime and the other half at bedtime. That way it wears off better and they have less of that hangover, or some ratio like that. That where you split the dose. Now, trazodone hits you in about 40 minutes. So you want to be able to get on a train when it's leaving the station. Okay. So when it hits you, what some people do is they take the sleep aid and then they're watching something on TV that's very exciting, and then they miss that window. So it does help with onset, but the bigger thing is the quality of sleep. And that's especially true whenever you're dealing with an infectious disease or any chronic illness. You want that quality of sleep, which is stage 3, stage 4 delta sleep, that's usually in the first half of the night.
Great. And I also learned from you some of the other drugs, which I learned from you years ago, like low-dose doxepin, 10 milligrams, especially in people with mast cell, for example. It's a good histamine blocker, or low-dose Remeron. Can you talk a little bit about some of these other meds that you like for sleep?
Well, there's a quote from the quote is the young physician uses 10 drugs to treat one condition. So that was their quote. And the older physician uses one drug to treat 10 conditions. And I guess you could call me an older doctor now. Okay. So if you look at a drug like doxepin, it's antidepressant, anti-anxiety. It's also antihistamine. It reduces itch. It is very good as an antacid. It's wonderful for reflux and irritable bowel. And there's something about it with a pacemaker, with the GI tract. So anybody that has GI spasm, usually 30 milligrams is a magical dose, sometimes a little bit more, sometimes a little bit less. And it's so that has many uses. So a lot of times then I can give one thing that helps multiple symptoms that may be driving the illness. And that's a very efficient treatment. And it's a cheap generic besides. So you're not fighting with insurance companies. Now it's actually FDA approved as a 3 milligram and a 6 milligram sleep aid, but it's the common dose. They're coming 10, 25, 50, 75, 100. And for depression, we often use 75 to 150 higher doses. But for these other uses, we give the lower dose. Now, it may increase weight gain with some people, not with everybody. So you always have to negotiate. It can do this for you, and these are the potential side effects. What trade-off are you okay with? And some people, and just because it can doesn't mean it does with everybody. So you always have to have that discussion of risk benefit and individualize how you respond to it individually.
Right. And the trick it's interesting you mentioned that with the higher doses. I found with the insurance companies, they don't usually like the 3 milligram or 6 milligram. They want to charge patients hundreds of dollars for them. But if you take the 10 milligram and you open up the capsule, and I've done this sometimes, and use tiny doses of it, right? I'm finding
Right.
that it's a way you can get away with it because the half-life of doxepin's long, and you got to be careful with the antihistaminic. It can make people drowsy the next day, right?
Right. That's what I do. And there's a liquid form of it too.
Right.
And a liquid form allows someone to titrate it fine. And you can open up those capsules. It doesn't have to be precise, but it is, that's because Silenor was the brand drug. And I think it's still brand. I'm not sure if there's a generic version, but even if there is a generic version, it's overpriced. And you
Yes.
always have to go on these websites like GoodRx to see what the price is, and that you're not using a pharmacy that's going to rip you off,
Right.
which there can be a big disparity in what different pharmacies charge, especially with generics.
Right. Bob, tell us a little bit about, because again, one of the ones I learned from you is low dose
Yeah.
Remeron, an antidepressant, but it's almost ridiculous because the lower the dose, right, of the drug, the better it works for sleep.
Right.
Talk a little bit about that paradoxical effect with it.
Now, Remeron, that's another one that you would think of in that category with doxepin. Remeron's a unique drug with 3 different mechanisms. At a low dose, it's more antihistaminic. And then as you go higher, you get more a serotonin effect. And then when you go higher, you get a noradrenergic effect. So there can be what's called a therapeutic window, but that window is very different in different people. So some people get that best response at a very low dose. And there were times when Remeron first came out, we would take Remeron, it's 15 milligrams, would cut it in half. So you'd have 7.5 milligrams, put it in an 8-ounce bottle of water and have the person take 1 ounce, because some people are very, very sensitive to very low doses. And you could very easily overdose. And that's true with a lot of psych meds. So sometimes you had to really titrate it that low. But then there's other people where you can go 30 milligrams and 45. And then it also, they're still not, you get more sedation. So there's a big variability. Now that also has a good effect with stabilizing the GI tract, similar to the doxepin. So both of them have a good effect on GI spasm. It's not, it doesn't have the antacid effect that doxepin has, but it's and it does promote the deep sleep, and
Yeah.
it's an affordable generic. Although ironically, the 7.5s are more expensive than the 15s because it's a less commonly prescribed dose. But it's you can chop up the 15s, but it's a good one, and you rarely see someone get manic from it. Although if you go too high with the dose, that would be a concern,
Right.
and that's a consideration.
So, Bob, just one quick question. If people want to contact you, how do they get in touch with you? You've been a great member of this community. I know a lot of people are going to probably want to speak to you after this. How can they get in contact with you?
Don't, please. I feel sorry for my staff. They get all these calls from people begging. I hope to train other people. This is everywhere. It's when I organized what we call MMI, although if it's a physician who wants to learn more, I have a discussion group on the internet I've been doing for 25 years. They could join that and learn more. But I can't do it all. It's just too many patients. So
So,
what
so
you
again,
want
to
to,
learn that it's MMI is microbes and mental illness, right?
yes, yes, get their doctor to join MMI. What they need to do is get someone else to learn more about it. And they can learn from different things, read what I've done 40 different journal articles. They could read about that, but they need to get their local doctors more involved. This is too big for you and I. You have the same problem, I'm sure, with all the phone calls you get. And we can't see all these people. We have to educate other people, and patients have to advocate for their doctors to learn more about that and don't feel they can just send all these cases to the handful of us that have more experience. They need to learn about it.
So for the ones that can't get in touch, because you're right, Bob, I have the same problem you do, which is we're only one person, but you've extensively published in the medical literature on the neuropsychiatric symptoms of Lyme. I mean, almost more than anyone except for maybe Brian Fallon, and really highlight, the problems with suicide and how you can get Lyme psychosis that's due to Lyme and Bartonella. I mean, I think you've made big contributions to the field. So I would also advise people read your articles, right, to understand it,
Yes.
especially if you're a physician, join MMI. And will you be speaking at any upcoming conferences where people can learn about what you're doing?
Yes, I'll be speaking at the American Psychiatric Association yearly convention in New York City. And we'll be talking about psychiatric long hauler syndrome. And that would be, in addition, Brian Fallon and Rosalie Greenberg, the three of us. We had a presentation approved. We will touch on Lyme disease and other residual psychiatric syndromes that you see as a result of these chronic infections. And I'm glad that they accepted our proposal, because I think this whole thing with long hauler with COVID just identifies something that's always been there with many other infections.
Right.
And it's a
And
new
what's
name.
interesting about the long COVID piece, and you mentioned
Yes.
this earlier, infections, immune dysfunction, and inflammation is driving the symptoms of Lyme and co-infections, but it's doing the same thing in long COVID because we're seeing the same overlaps, right? With the
Yes.
fatigue and the sleep disorders and the POTS dysautonomia and adrenal dysfunction, microbiome abnormalities, mast cell, right? I mean, all of these things, viral reactivation with Epstein-Barr or persistence.
Yes.
We're seeing exactly the same things with long COVID that we are with Lyme.
Long hauler is a new name to a very, very old phenomena that we've been dealing with for a long time. And it's been usually a complex interactive infection. It's not a single thing. It's an complex interactive infection.
Right.
And it points it out. It's similar to what you see with AIDS. HIV has a similar dynamic. You can't just look at you can't just look at COVID. You can't just look at Borrelia. You have to look at the interactive mix.
Right. Now, you speaking about inflammation, you have published actually, and I've seen your talks on this, on the role of inflammation, right, causing neuropsychiatric symptoms, causing sleep disorders. Can you talk a little bit about the triggers? Like what would exacerbate sleep in some of these patients? What are the underlying inflammatory factors you see that's a
And now think of inflammation. If you think, how's the immune system work? So if I think of those three interlocking circles, infection, other drivers, immune, and then symptoms. So we'll talk about the immune for a minute. Now, if someone sneezes on me, I get early inflammation, and then I get adaptive immunity, and now I'm fine, and it's done. And we don't see that. We don't see that with a lot of these Lyme patients. Instead, we see early inflammation, and there is not adaptive immunity. So there's persistent inflammation and there's autoimmunity because it's never done. There's not adaptive immunity. And now, normally, inflammation can be from chronic stress. So anything that gives you chronic stress. So there's a vicious cycle. You have a chronic illness that limits you, and now you're chronically stressed, and you're also sleep deprived, and that contributes to the disease progression and perpetuation. So inflammation can be from other things, other insults, but it's why is there that failure to shift adaptive immunity? It's and the immune system reacts through danger. Now, post-traumatic stress can be a big part of it. Adverse childhood events is the phrase that we've used in recent years. So let's say someone has old childhood trauma, and now they're constantly in that high stress. You're thinking of stress syndrome versus sickness syndrome. Now, syndrome is I'm in a war zone and I'm fighting. I forget internal recovery. I have to deal with my environment. Sickness syndrome is the opposite, where I came down with an infection yesterday. I stay home from work. I curl up in a ball. I sleep. I have brain fog. I do nothing. I just vegetate for a couple of days and now I'm fine. So, but the problem is when you have both stress syndrome and sickness syndrome at the same time.
Right.
Then
And of course, Lyme, and you and I see this all the time.
Yes.
Lyme, Babesia, Bartonella are chronic persistent infections, right? They're driving inflammation. And when you don't sleep, you get this increase in inflammatory cytokines like IL-6. So it's like throwing gasoline on the fire when they're not sleeping, right? Pushing out all those symptoms you're getting from the
It's
co-infection.
like, how do these, in medical school, we use the phrase Saint Sebastian diagram, okay? Where you have this big diagram with all these arrows. And what's the vicious cycle that keeps it going? Where can you intervene that makes the most difference? And like I mentioned, sleep is a major one, but not the only one. Chronic stress is another one. What drives the chronic inflammation? And you don't want to just knock out the immune system like with a sledgehammer. That's catastrophic because there's a chronic infection.
Right.
And that often happens with some genius who clobbers somebody with steroids. They get a honeymoon period for a while, and then when the steroids stop, then they relapse because the infection got worse. So it's you're trying to tweak the immune system so you have adaptive immunity, and the immune system, there's not the friendly fire. When we think of friendly fire, part of that's inflammation, part of it's autoimmunity, but it's not targeted towards correcting the danger. It's harming the body instead of attacking the danger.
So Bob, when people have the kind of stress and they all come in, I discuss with people affectionately that the people that come to me, I call them the walking wounded, because so many people have had emotional trauma, whether it's physical, sexual trauma, emotional trauma, whatever it is. Almost everyone coming to my office has it. And you're saying it does disrupt the sleep cycle. Like I'll do DHEA cortisol testing and find at night the cortisol levels are off the wall. They've reversed it. So they're up at night and sleeping during the day. So, I'll use herbs like phosphatidylserine, sometimes to bring down that cortisol response. What do you like for these people that are so stressed out that their mind can't shut off? You were discussing this earlier. What do you like meditation? Do you like neurofeedback? What are you suggesting?
Anything that works, and different things that work for other people, white sound and everything. So here's another part of it with the sleep that I want to mention is, and this is rather unique to Lyme. Lyme patients often get sensory flooding, sensory overload. It's different than attention deficit disorder. Attention deficit disorder, it's distractibility. You can get that with Lyme too, but it's sensory flooding. So you see this with people on the spectrum also, where it's too much stimulation. I can't take it. The noise of the day is too much for me. So at night, now there's less stimulation, and now I can hear myself think. So a lot of Lyme patients become night owls because they have, it's a lower level of stimulation. They can better tolerate it. That's one group. Another group is, let's say someone had sexual trauma at night, and with a nighttime intruder, that person then at night they get hyper aroused, hyper vigilant, and they can't relax, and you get a reversal of circadian rhythm. You're trying to normalize a circadian rhythm. You want to be awake when you're awake and functional and productive, and you want to be asleep and recovering when you're asleep. But a lot of these chronic illnesses, you're half awake and half asleep 24/7. And that's what you don't want. You want to, and it's not just nighttime, it's the entire 24-hour cycle. So part of that's habits. What do you do during the day that's energizing and motivating, and the timing of it? When do you do your exercise, your diet, those type of things, and so that you have a normal circadian rhythm instead of a reverse circadian rhythm or a flat circadian rhythm.
Right. So Bob, as far as these, you were talking a little bit about you need to be awake when you're awake, which when I learned this from you years ago, you were talking about activating agents in the morning
Yes,
using things that I wouldn't have normally thought of, like bupropion to raise dopamine, right?
yes.
And then things at night. So can you talk a little bit about the activating agents of how you get people up in the morning sometimes when they're just completely wiped out? And apart from the trazodone, doxepin, Remeron, like what other tricks do you have at night and what other herbs do you like for people for sleep?
Well, for instance, I think one thing is melatonin is good in making someone sleepy. So when I was talking about being able to calm, quiet your thoughts, calm your emotions, relax your body, but then you have to feel sleepy. Some people can do that and not feel sleepy. Although you don't want so much melatonin that you get a carryover and there's too much the next day that then disrupts your cycle. So you don't want any sleep aid that gives too much of a hangover, any sleep aid, or you don't want an activating agent that works too long in the day that interferes with the ability to fall asleep. So
Like Vyvanse and stimulants, right?
right, you want the right dose and the right timing. Okay. So if someone's a slow metabolizer, Vyvanse might be bad because it might last too long. They might then do better on Adderall XR or plain Adderall. Although now, if you think of the stimulants like the Schedule II stimulants, which are amphetamines or methylphenidate, your problem there can be, they're Schedule II, they're stronger. Some people end up on those, but I don't start with those. Uh, Provigil, Nuvigil, Wellbutrin, some of the activating antidepressants, they can be good, and but you want the right amount and the right timing. And now that the Provigil, Nuvigil, that's modafinil, armodafinil are generic, they used to be, $1,500 or so when they and these pharmacy plans when they're approved. Now they're generic, so now they're very affordable. And when they work, if they work, they can help wakefulness, fatigue, concentration, initiative. It could
So
be any of those four things or none of those four things.
right. So do you use modafinil or either Provigil or Nuvigil? Do you use
Yeah,
it sometimes with bupropion, like if they need even more of an activation in the
yeah,
morning?
yeah. Sometimes now the bupropion, the Wellbutrin, what that's good for, particularly if there's anhedonia. Now, if I say, "Hey, let's go do such and such," are you up for it? And in order, I'm looking at your motivation here. Okay. Now think of your motivation as a chair with three legs. Okay. Now one leg is the anticipation of pleasure. Okay. So if I say, hey, let's go on a vacation to Key West or whatever. Okay. Now, are you going to say yes or no? Now, part would be, would you enjoy it? Can you anticipate that it would be enjoyable? And if you think, wow, that'd be fun, I'm up for that. I'm psyched up. I want to really go for it. So that's one part. And people that have, for instance, a low dopamine, they have anhedonia and they don't feel the pleasure of life. Now, interestingly, the disulfiram does work in that area in increasing dopamine too. Okay. So that's a bit of an antidepressant effect it has in addition to being antimicrobial. So that's one leg of that stool. Then the other is, do you have the mental and physical energy? Now, if you have fatigue and you're paralyzed by fatigue, oh, I just don't have the energy to do it. It just takes so much energy. Now, fatigue is different than exhaustion. Fatigue, now, exhaustion is I ran a marathon this morning at a mile 26. I was exhausted, but I had something to show for it. Mental fatigue is I wrote a term paper, 30-page term paper, and my brain is dead, but I had something to show for it. Fatigue is I slept 12 hours and I feel like I ran a marathon and I have no energy. Okay. So fatigue is the second leg. The third leg is executive functioning, the ability to create and sustain goal directed behavior. And I say, okay, do you have the capability to figure out, get the tickets, figure out the flights, get packed, organize, get to the airport, do all the planning involved. So you need those three pieces to be motivated. And I'm using that as an example, but it could just be day-to-day activities. You need the pleasure, the anticipation pleasure, you need the energy, and you need the cognitive focus, executive functioning to pull it off. And if you have those three things, then you can initiate and attack the world and go for it. But if one of those is missing, then you'll be apathetic and it'll be hard to get moving. So in deciding it, if it's more the lack of pleasure of life, I give more the bupropion. If it's more the fatigue, then I think, well, have I done more to improve deep sleep? And that's where I might use the Nuvigil Provigil or the executive functioning. It may work there. Okay.
Right. And of course, in my population, I think you see it also. The overlapping causes of fatigue. I mean, pos dysautonomia, low blood pressure
Yes.
causes
Yeah.
fatigue. We see low adrenal function in over 95% of our patients. They don't have the hormones, right, to give them the get
Right.
up and go, or the mitochondrial been affected, or they've got the wrong bacteria in the gut with mast cell disorder, or the infections are still active, right? It's a huge number of things that affect it.
Although the low hormones ties in with the lack of restorative sleep, because when you get the deep sleep, then that triggers growth hormone. Growth hormone's the master hormone that then helps with the sex hormones, and it's not just infection and the immune system. It also, and thyroid and cortisol, it helps to normalize the body's 24-hour clock of hormonal functioning. So that goes back to sleep again.
Right, because men they get low testosterone, right? They lose like 15% at least of their testosterone if they don't get enough sleep. And I mean, now
Yes.
they're even linking up sleep. And this is an important point for people listening. The reason they have to get to sleep is they're now associated, right, with Alzheimer's disease as being one of these
Right.
causes of dementia later in life.
Right. There's a saying, sleep like a baby. And if you look at baby sleep, they have more delta sleep. And if you look at older people, they have less of the delta sleep. And that's when your body repairs. It's when the brain takes the garbage out. When you're in deep sleep, the space between the neurons enlarges, the intracellular space, it's called. And it helps flush out the waste products from the brain. If you're not getting that, then you're not recovering, and it contributes to neurodegeneration. And you have to be careful. Like when we were residents or interns, there's a stoicism of go without sleep, just like a military thing. But that's terrible. It makes you impaired, and it shortens your lifespan, and it makes you susceptible to everything, including dementia.
Yeah. With the sleep meds we're talking about, and we talked a little bit about trazodone, doxepin, Remeron. One of the other ones you shared with me years ago that I find particularly useful is Lyrica, pregabalin, because
Yes.
when I'm doing my dapsone protocol now, some of these drugs we've been discussing can affect the QT interval on the electrocardiogram, right? They interact with SSRIs, SNRIs, PPIs, et cetera.
Yeah.
I found that Lyrica pregabalin, 50, 100 milligrams, it does not interact with methylene blue. And for some people, it's good for fibro and it helps with sleep. Talk a little bit about Lyrica
Well,
pregabalin.
it's like when you have pain, you think of the dual acting antidepressants, and they have the serotonin mechanism. Lyrica can help pain, and it's not a serotonin mechanism. So then you don't have to worry about the methylene blue. So Lyrica and gabapentin both. And some people do better on one or the other, or they tolerate one or the other. Occasionally I might get both. But it does help with promoting deeper sleep. And there are studies showing it promotes the deeper sleep, but it also helps pain. Now, if you get better sleep, you have better pain control. That's another thing about sleep. But separate and apart from that, it helps pain, particularly neuropathic pain. But I think Lyrica, it does help nociceptive pain to some degree also. So a lot of times it's part of your chronic pain management, and it's something that can work. It also is anti-anxiety, and it helps with neuropathy. A lot of Lyme patients have neuropathy. So there's multiple benefits to it. And again, you're back to that one drug having 10 effects. That's one of these drugs that can have 10 effects. So I use a fair amount of it. Now, the way they did the studies, they split the dose, half in the morning, half in the evening. Usually I would give a third in the morning and 2/3 in the evening. I usually started at night, and some people I just only give it at night. But then I may give a lesser dose during the day, but it's the bigger dose always at night.
I've done the same thing, and I learned that from you. And I'm generally trying just to use it at night. But you're right; it's at least 2/3 at night, a third, so people don't get drowsy, because already from the co-infections and Lyme, right? It's a problem with chronic fatigue, and oftentimes, by the way, I'll mix it with things like melatonin. We talked about low dose, which also blocks an inflammatory pathway they've seen in COVID, NLRP3 inflammasomes, right?
Mhm.
I'll use GABA-L-theanine. I actually like GABA-L-theanine. One of the companies, Ortho, makes Copacom. I use valerian root. Like I'm mixing in a lot of herbs and sometimes things to lower down the adrenal at night with these medicines. And I find oftentimes that approach, right, at least works for some of my patients who are very resistant.
So I think everybody's different. And there's an argument against some people is unproven treatments. But whenever a study is done, it's done on aggregate data, aggregate patients. We don't treat aggregate patients. We treat one patient at a time. And what worked for their twin sibling doesn't work for them a lot of times.
Right.
Everything must be individualized, especially the dose. And that's the evidence is more clinical observation. And these studies are interesting, but they only have so much relevance to the patient in front of us. We always
Because
have to
because it's all personalized, right? Because ultimately it's got to be
yes,
personalized to the people in front of you.
yes. And public health people get carried away with aggregate data being predictive, and it never is with an individual patient. It
Mhm.
gives a rough estimate, but it you can't be dogmatic about it. You always have to individualize.
Yeah. So, Bob, one of the important points I think we're bringing up, and not just for psychiatrists, for anyone, I always kind of wondered why so many psychiatrists miss the effect of Lyme and Bartonella and these co-infections in the psych community. You developed a clinical diagnostic system. You were talking like over 200 questions you asked. Where do
Right.
people find this questionnaire? And how do you determine? Because the real thing that I learned, like even from Brian years ago, was that if it's atypical symptoms at a later age and it's not fitting the classic paradigm, and the drugs you're going to use, like say lithium or whatever for bipolar, it's not working. Like, how do you determine, especially with the physical symptoms,
Right.
that there is a physical component to the psychiatric issues that you're seeing?
Certainly, the greater the comorbidity, the greater likelihood might be something like Lyme. Now, it's actually in the American Psychiatric Association guidelines for the treatment of for the assessment of adults to consider Lyme disease as a cause. So the American Psychiatric Association recognizes this in their guidelines. Okay, it's not just the ILAD guidelines that recognize; it's the American Psychiatric Association, a much larger organization than the IDSA, I might add. Okay. Now, so anyway, I think a lot of like we have what's called the DSM-5, okay? And that's a diagnostic and statistical manual. So it divides different things and say, well, this is how you diagnose attention deficit disorder, depression, panic disorder, et cetera, et cetera. It addresses the clinical presentation, but it does not address the causality, okay? We're looking at causality here, not just the clinical presentation. So if you say, well, someone's depressed, we can give an antidepressant and that manages it. But what caused the depression in the first place? If you go further and look at causality and think of it like a row of dominoes, it's easier to stop an avalanche at the top of the mountain than the bottom. If you can understand causality, you have more treatment options. And a lot of doctors are more trained as not just psychiatry, but I think everywhere to treat the end result and not to go backwards and to say what caused in the first place. Now, if we look at what causes mental illness, and that's why I wrote this article, and is it's an interaction of an environmental trigger and a susceptibility. And there really isn't much in the way of mental illness genes. There's susceptibility genes. But because you see identical twins and one has the illness and the other, you it just doesn't make sense that most of mental illness is genes. So
So
it's
all that we saw about schizophrenia years ago and genetic predispositions and stuff, what you're seeing is that there may be specific environmental triggers, right? And that especially microbes in mental illness or even environmental toxins, right? They can also cause a whole host of problems with this.
right. Like in my article with Dr. Greenberg and Dr. Charlotte Mao, Rosie Greenberg and Charlotte Mao, we looked at schizophrenia and we looked at all the infectious articles supporting it. We looked at autism. We looked at bipolar. We looked at depression. We looked at anxiety disorders. We looked at suicide. We looked at violence. And you could see that there were a lot of the same usual suspects that kept reappearing. And there were a lot of different infections that came up. And for instance, when polio was around, there was a strong correlation with polio and schizophrenia. But it wasn't just polio. There's a lot of different infections. And then particularly at a critical phase in development, and then that impacts development, and then you lay the foundation for it. So some of these are infections like we see where someone's 30 years old and they decline, but others you see where the die may have been cast in congenital, in utero, or in early childhood, and now it's the end result of what a damage that was done years before. But there's an awful lot of infection connecting this, and then it's immune mediated. You get the infection, you have some degree of genetic susceptibility, and then you have immune pathophysiology, and you have to look at not just the neurotransmitter system of the brain, but the immune system of the brain, because they're two parallel communication networks. And when someone goes from health to illness and then recovery, and then you look at genes that are upregulated and downregulated, a lot of those genes that are upregulated and downregulated are immune system genes, more so than neurotransmitter genes.
Right. By the way, when you're looking at these genetics, I mean, I occasionally do it, but do you use things like the genome? Do you look at genetic variants and COMT, and all these different pathways when you're giving these medicines to see how they're working? Or you don't think it's like, you think it's
No,
essential or just individualized?
no, it's in like I can tell who's. For instance, I think a lot of people don't know how to use those, and they think, well, this is the antidepressant for you, and it doesn't mean that at all. All it shows is that we predict that you would be a rapid or a slow metabolizer of this drug, so you need a high dose or a low dose. But now it may show some susceptibility, and it may have some value, but a lot of I've been so used to figuring that out. I know who's a rapid metabolizer, slow metabolizer. I can figure that out.
Mhm.
I don't need a test to show it. And
Well, and of course, the problem is when I use drugs like rifampin, that's in every protocol pretty much I'm using,
yeah,
it's changing the metabolic pathways for all these people, right? As far as their other drugs.
yeah. So it's tricky. Then you have to make a dosage. See, a lot of people think that with drug interactions, it's going to be toxic and scary. And I think, for instance, serotonin syndrome is often overstated with some of these warnings. But when you add rifampin or whatever, okay, so there it's the 3A4 drug is metabolized faster. You just adjust the dose.
Yeah.
And then when you stop it, you have to know you have to adjust it again.
Right.
But the problem would be if you're doing a cyclic treatment on and off, and then you have some other 3 or 4 drug, then you'd be all over the place. You can't do that.
Yeah.
So you have to know and make the adjustments. Now, some of these drugs we can do blood levels on, and others we don't. So others some we can go by the numbers, and others we just go by the clinical response.
Right. Question, other tricks for people. I mean, sometimes when I'm taking a sleep history, because again, the Lyme patients don't fall asleep, they keep waking up, or they sleep for 16 hours and they have unrefreshed sleep. Right? I mean, it's
Right.
common, most of them. Like I didn't used to be so sensitive to caffeine. I could drink literally an espresso an hour 30 years ago. And now if I do it past 2 or 3 o'clock, I can't sleep. Or if I have dark chocolate at night, turning into theobromine, I can't sleep. Can you talk a little bit about food, diet, blood sugar swings, hypoglycemia, things that maybe people aren't thinking about that might also affect their sleep schedules?
Yeah, well, also, the sleep schedule isn't 24 hours, it's like 12 hours. So what normally happens is, let me give a normal sleep schedule. I jump out of bed at 7 o'clock in the morning and I say, I want to attack the world and conquer mental illness. Okay. So now I have energy, and now it's 4 in the afternoon. So that's a normal biorhythm slump that we all get. And if I were in Italy or Spain or an equatorial region, I'd have a siesta. And it is a normal biorhythm slump that we all have. If I were in England, I would have tea and crumpets at 4 o'clock. But if I'm in New York, I'd have 4 glasses of Starbucks and push through it. Okay. And because that's the culture and that you do now, but it is a slump time. So don't do something that requires strong focus at 4 in the afternoon. And then after that, then you get a second wind. Now you also get blood sugar fluctuations. So I may put someone, let's say, on a stimulant medication that inhibits their appetite, and then they skip lunch, and then that 4 o'clock drop is even more magnified. So that's sometimes can make the person worse. And you have to be careful, particularly a lot of people go towards sugar and these things that you get at the convenience stores, these all kinds of junk that's there, but a lot of it's high sugar, high caffeine, and uh, and that can cause a hyper and then a crash.
Right. So in
And
other words, people who are listening, they have to be careful that regular exercises we know really helps with sleep, right? You get much better quality sleep.
but the timing of it, right?
Right.
The best sleep I ever had was when I was backpacking in the mountains, and when I would lie down, all of a sudden it would be morning because, but we usually have a rather sedentary lifestyle. And a lot of our younger people, they spend their time exercising their fingers with, video games. We used to go out and play in the street with other kids, so they don't do things that make them tired. So you want to do something physical, you want to do something mental and physical, but you don't want to do it so close to bedtime that it stimulates you.
Right.
You
Right.
want to do it at the right time of day, and you have to look at your whole 24-hour clock. Here's the other thing that people do that's a mistake. It's you lie down and then you think of the problems of the day that were unsolved and the issues of tomorrow that you need to attack that you're not sure about doing, and all those go racing through your head. And that's, we call that silent episodic random thinking. But what you should do is set a time of the day when you sit down and you say, okay, what happened to me today? How has that affected me? And how am I going to go about things that's different? What's my plan? And you do it, and you do it when you can do it right. And when you're lying in bed at night trying to sleep, you can't do it right.
Right. So your advice really is take some time during the day if you've got a sleep disorder with a pen and paper and sit
Yes,
down and download what
right,
are the issues you're dealing with,
right.
problems, solutions, get it out of your brain so you're not dealing with it right at 1 o'clock in the morning.
And what you could do is put a pad at the side of the bed, so if something pops in your head that, oh, I got to think about this, you write it down, and that way you can get it out of your head. Okay? That, and see, silent episodic random thinking, think of it like this. Your heart will beat whether you want it to or not. Likewise, your brain will think whether you want it to or not. You can't make your brain stop thinking. But what you can do is think about more monotonous things. That's the whole idea of counting sheep. And I don't know, did you ever see the movie Amadeus?
Yes, many, many years ago.
Okay. Wonderful
F.
movie.
Murray Abraham did a great job in it.
But there was one scene in that movie with Mozart. It's, oh, the music, it just won't stop. Okay. Remember that scene? Okay. But it's a wonderful scene, and some people just have a lot of brain activity, whether it's being musical creation or coming up with new ideas about how to treat Lyme disease. And hey, it's 1 a.m, but I got this new strategy that might work. You have to be able to turn it off, and your brain spontaneous. And some people have more of this than others. Okay. That creative spontaneous thought that just comes.
Right.
And but you
So keep
write it
that pen and
down,
paper nearby just so you can download and therefore get it out of your brain so you can get back to sleep.
get it. I'd say, I'll think about this tomorrow. I'll think about this when I'm driving on the parkway, and that way I can put it together when I can really think about it. But
Right.
now when I'm trying to sleep, I'm not going to do a good job. That's a mistake a lot of people make with trying to sleep. But you
Right.
have to, some people do it when they're commuting back and forth to work, but you have to have a time that you set that aside. And it's not when you're trying to fall asleep.
Yeah. So, Bob, we're getting to the end. Boy, that went quickly. We're getting to the end of our interview. Just last question for you, and then we can kind of recap a bit. What do you think about Lyme leading to other neurological illnesses, systemic issues, sleep, and like immune recovery process in Lyme? Just kind of sum it up a little bit for us. Medications, herbs, the importance of this. And again, a little bit going back to MMI so people can learn more about the work that you've been doing.
Well, of course, all medicine is based on modern medicine is based on herbal medicine. And I could think of the example of digitalis. that I could go by the side of the Garden State Parkway here and pull some foxglove and chew on it, and I get digitalis, or I could get it from the pharmacy. It's the same thing, although probably what's next to the parkway maybe has some contamination from all the highway pollution. Okay. But and any drug you can trace what was the evolution of it. Okay. So it's whatever works. Okay. But I think when we're making progress with all this. We're, you have to keep trying and individualizing, and everybody responds to something different.
Right. So the point is, don't give up. I mean, for
Yeah.
example, in my Lyme community, once I adequately treat the Lyme and the Bartonella or the Babesia, and I've treated their POTS and gotten their immune system in order, and I've dealt with the adrenals, they do get to sleep. But oftentimes, I'm using probably 3 or 4 different herbs. I may be using melatonin and CBD and gabapentin and valerian root, right? All of these things with some low dose Remeron and some low dose Lyrica pregabalin, right? And a little trazodone. And I have to do mixing and matching for these individual, right? Or
although you're always trying to think, why are they not sleeping? And that answer isn't always that clear.
Right.
And
but that goes back to the need for the sleep studies to figure out, as you were talking about, even if you're a young, thin woman, you can have obstructive sleep apnea or restless legs or narcolepsy, cataplexy. So you've really got to get to the underlying causes. Is it hormonal? Is it trauma? Is it POTS dysautonomia? The infection still active? It's really getting back to personalized medicine and going down the list.
I have seen every single sleep disorder there is associated with Lyme disease, be it restless leg or sleep paralysis or hypnagogic hallucinations or cataplexy, or everything.
Right. And of course, and I know we touched on this earlier, now they're showing that chronic sleep deprivation, even starting in your 40s, apart from cardiovascular risks of heart attacks and strokes, is being associated with dementia, metabolic syndrome, especially the people who have the working the night shifts, right? I mean, those are some of the ones that have some of the worst sleep disorders.
Although some of this, for instance, with the sleep disorders, there may be someone who's predisposed to sleep apnea and then they get Lyme. That's maybe why they're not recovering. Or there may be someone who gets Lyme and then gets a sleep apnea as a result. So sometimes with these things, it's like, which came first? But either way, you have to untangle it and address it.
Right. Bob, it was a great conversation today. I want to really thank you for joining me. For those of you who managed to tune into this whole conversation, we've been talking with Dr. Robert Bransfield, one of the leaders in neuropsychiatric Lyme and tick-borne, I would say, in the world. At this point, we've been talking about sleep disorders in this Healing Lyme Summit. And Bob, I just want to thank you again for taking the time today to speak to me. And again, don't contact Bob, but get in touch, read his articles, right? The man needs a break after all these years. Read his articles, go on the MMI forum. And will you be at ILEDS later this year, Bob? Will you be?
Yes, I'll be there, and I'll be in the ILEDS in Germany. And I hope I kept everybody awake talking about sleep disorders. Okay.
Not a problem. It was a great talk, Bob. I always appreciate talking to you. So I want to thank everybody again, and hopefully we'll see you again for the next episode from the Healing Lyme Summit. So thank you so much for joining us today. This is Dr. Richard Horowitz, your co-host, and Bob Bransfield. Thank you again.